Hello, I'm Giuseppe Vanella, a gastroenterologist and pancreatic endoscopist at San Raffaele Scientific Institute in Milan, Italy. I would like to thank Gastrointestinal Endoscopy for giving me the opportunity to share some insights about our recently published paper entitled EUS-guided gastroenterostomy for management of malignant gastric obstruction, a prospective cohort study with matched comparison with enteral stenting. During my fellowship at the EUS-guided Belgium, I was introduced to EUS-guided gastroenterostomy and felt the enthusiasm of Professor Vanella around this technique. I was surprised at how much this was already included into daily clinical practice. However, at that time, the evidence was mostly retrospective and there was an extreme urgency for prospective data. Upon returning to Italy and starting to work with Professor Accidiacono and Dr. Capurso in a tertiary referral academic center specialized in pancreatic diseases, we felt that this was a perfect environment for this aim, and we started enrolling all interventional EUS procedures into a prospective registry of therapeutic endoscopic ultrasound, the so-called PROTECT registry. This registry not only included EUS-guided interventions, but also standard comparators, such as in this case, enteral stenting. We started following these patients day by day, month by month, and as soon as their number increased, we immediately had the perception that a revolution was happening. As gastroenterologists used to enteral stenting, we were aware of the limitations of these procedures. Some patients were unable to restart eating after the procedure, and the risk of obstruction and reintervention was really high during follow-up. Whereas the impression was that EUS-guided gastroenterostomy was working much better both in the very beginning and during follow-up. We expected that a prospective follow-up would lead to a higher detection of adverse events or dysfunctions that were missed by retrospective evaluations. Conversely, we were surprised to how well these patients were doing after EUS-guided gastroenterostomy and how grateful they were for the possibility to eat. This went in parallel with initial society recommendations, starting to suggest to avoid enteral stenting in patients with expected longer survival due to the risk of reintervention. Thanks to the engagement of the whole hospital, surgeons, oncologists, all physicians in the multidisciplinary team, and these initial promising results, this rapidly led to a conversion to of EUS-guided gastroenterostomy as an upfront treatment strategy for all those patients who were fit enough for the procedure. And the general rule for us has been that the patients had to be able to tolerate an eventual backup surgery in case of misdeployment. However, luckily, this event was much rarer than reported from retrospective series in our center. Of course, there were still patients with higher frailty or advanced disease, or patients for whom EUS-guided gastroenterostomy was contraindicated, such as ascites or rhinitis plastica, and these patients underwent enteral stenting. However, we wanted to compare the two procedures, but these two groups were not randomly created, and we therefore matched patients undergoing enteral stenting with patients with the same frailty or oncological status undergoing EUS-guided gastroenterostomy, and creating two groups with similar baseline characteristics. And still, EUS-guided gastroenterostomy was able to prove its advantages in terms of significantly higher primary clinical success, 100% versus 75%, reduced time to chemotherapy, and reduced dysfunction during follow-up, 4% versus 33%, without any increased invasiveness. This is not only the largest prospective series of EUS-guided gastroenterostomy available to date, to the best of our knowledge, and the first prospective comparison with enteral stenting, but it has also the opportunity to show how the clinical practice of a tertiary referral institution has changed after the introduction of the technique, demonstrating outcomes that are difficult to explore in retrospective evaluations. For example, what is the rate of planned EUS-guided gastroenterostomy that were converted to enteral stenting due to intraprocedural contraindications. Furthermore, after a larger acceptance of the technique, is there still a proportion of patients who are candidate for alternative procedures such as upfront enteral stenting? And even if it's true that we used a single technique, the so-called wireless simplified or WEST technique, to perform all the procedures, what changes were made during the study interval to improve the outcomes? Several illustrations are also included in the manuscript, which describe each single technical step of the procedure, including signs of correct lamps placement, and as for example, endoscopic appearance of intraprocedural contraindications or adverse events or recurrences detected during follow-up. While we wait for randomized data, we believe that this study has the potential to inform physicians involved in the management of hepatopancreaticobiliary and gastrointestinal malignancies about the increasingly established role of EUS-guided gastroenterostomy in clinical algorithms. We hope you might find our paper informative, and we invite you to share your thoughts and comments through social media or the corresponding address. I would like to thank also all co-authors for making this project possible. Thank you for your attention.